Our work is investigating connections between SPMs and lung health and disease. And in vulnerable populations, nutrition can be challenging. And we know that nutrition in the form of omega-3 fatty acids is essential for health. And unfortunately, some of our most vulnerable patients and citizens find themselves in nutrition deserts, even though they might be in a city. So bolstering a healthy diet, which includes dietary essential fatty acids, is really critical to lung health. So pretty much all of our work is based on the ability to have a healthy diet. So that's the way I think it would impact vulnerable patients the most. Thank you for the question. The lipoxins are produced by metabolism of arachidonic acid, which is also an essential fatty acid. It turns out that that essential fatty acid can be converted to many different molecules, some of which actually provoke asthma and asthma severity. Lipoxins are the natural braking signal that counters those pro-asthma mediators from arachidonic acid. And if you have low levels of lipoxins, there's an imbalance, and you have more of the pro-phlogistic mediators, pro-asthma mediators, and less of the brake or less of the counterbalance. And so asthma is a disease of chronic inflammation without cure. And so part of the rationale for why that may be is that there's a relative deficiency in these anti-inflammatory pro-resolving mediators such as lipoxins. It turns out the lipoxins, resolvins, and other SPMs have multiple ways that they can decrease inflammation and actually promote its resolution. And by decreasing inflammation and resolving it in a person who has asthma, their symptoms would go away. Their symptoms are typically chest tightness, wheeze, cough, shortness of breath, and all those would be made better. There are some people with asthma that their disease is not characterized by a lot of inflammation. So that would mean the lipoxins or the resolvins or the SPMs would also have to work on the structural cells of the airway of the lung, not just the white blood cells, the leukocytes. And it turns out that there are sites of action for these molecules on not just the immune cells, but also the structural cells. So that's a second way that lipoxins and SPMs can help improve asthma health. And then lastly, exacerbations of asthma, when people get really symptomatic, are most frequently caused as adults by viral infections. And it turns out that these natural pro-resolving mediators help the body fight off asthma exacerbations from viral infections. So through a combination of mechanisms, helping to quiet down inflammatory white blood cells, engaging structural cells in the lung to help quiet those cells that line the airway from their overactivity, and then helping to counter infections, enhancing your host defense. Those are three ways that lipoxins and other SPMs could help with asthma. That's a great question, and it's really timely given the COVID pandemic. And we're in the middle of influenza season, which can also cause very serious viral pneumonias. And in the very young and the very old, we also see respiratory syncytial virus cause very serious respiratory viral infections, which can be pneumonia-like. So this is a really important question for our health, and it helps instruct aspects of our research programs to make this better. So an antiviral antibiotic is important, especially when there's an exposure to a large amount of virus. Some of the excess morbidity and mortality relates to a challenge for our bodies to clear virus. So the addition of an active antiviral antibiotic is helpful. But it's not just about the pathogen. It's also about the host response, our immune response to that same pathogen. So if you look at two individuals that get exposed to the same virus, one might end up with a cold or minimal disruption to their health, and the other one might end up in a hospital, life-threatened because of a severe pneumonia, on a ventilator in an intensive care unit. It's not because the virus was different, it's because the body's response to the virus was different. And so some of those responses can be really robust to the point that it's like maladaptive. It's like too much, it's excess. And so we don't have good anti-inflammatory treatments for most viral infections. There have been a few instances where anti-inflammatory treatments have been shown to be helpful. For example, in some people with severe COVID, glucocorticoids can be helpful. But by and large, we don't have good information on this. So it's an area of active research and of global need. So there are two principal lines of defense in the lung for a respiratory virus. The airway is lined by cells that are called epithelial cells. And there's a group of molecules called type 3 interferons that are produced in the setting of a viral infection by the airway epithelial cells. That induces genes in the airway epithelial cells that neighbor those activated cells that have antiviral actions. So genes that produce proteins that can actually neutralize the virus. It doesn't activate the immune system. And so you can think of it as a skirmish at a border. So you can neutralize the virus without totally activating the immune system. The most well appreciated of these is something called lambda interferon, which is part of the type 3 interferons. Our second line of defense, which is of course important in serious viral infections, is from type 1 interferons. And type 1 interferons also produce in the airway antiviral proteins. But because it's your second line of defense, the virus has broken through the first line of defense, and so the troops get mobilized. And that activates your immune system. The most notable molecule of this second line of defense are gamma interferon. And we know that gamma interferon was produced at very high levels in the setting of severe COVID pneumonia, similarly with severe influenza, and this activates a very strong inflammatory response. And in the lung, we have very fine air spaces, which are critical for us to get oxygen into our bodies and to eliminate carbon dioxide. But if we have a very strong immune response in the lung starts to fill up with fluid, which compromises our ability to exchange gas, get oxygen, release carbon dioxide, and this causes severe shortness of breath and even respiratory failure. So that's the mechanisms that are relevant for hopefully that initial skirmish, and not the second line of defense with activation of a very robust immune response. But of course, we know that a serious respiratory virus, both the first and second line of defense get activated. It turns out that SPMs can actually induce that first line of defense, so you can produce more lambda interferon, and they also quiet down the second line of defense. So even though you might get an immune response, it's not quite so vigorous. And so this, of course, has some survival advantages, and you can still fight off the virus, but without that excess immune response. The importance of the first line of defense of the lambda interferon is emphasized by the development of a pegylated lambda interferon for treatment of outpatients who get COVID. And just this past year, a large clinical trial was done to prove that patients who get COVID, whether or not they're vaccinated, if they get a shot of pegylated interferon, lambda, they actually do better in terms of their experience with COVID. They have a more mild form, they don't have to go to the hospital or urgent care, there's fewer deaths and hospitalizations. So an endogenous natural product like SPMs that can induce interferon lambda in the body is an advantage in viral host defense. Recently, a study from the UK Biobank, which has looked at over 500,000 people's genomes, took an agnostic view to try to figure out prioritization of genes where there's variance related to asthma and asthma susceptibility. And of the genes that were identified, one of them was the receptor for resolvin D2, one of the SPMs, one of the DHA-derived SPMs. Well, that excited us to look to see mechanistically if that made sense. And so we turned to a mouse model of allergic airway responses that mimics some features of asthma. It's not asthma, but it mimics some of those features. And when we evoked that response, we used an extract of house dust mite, which is a very common clinical allergen that patients with asthma react to. And we got an allergic response that was typical, as expected. And when those mice received resolvin D2, they had lower amounts of type 2 inflammation. Their interleukin 4 levels were lower, as were their IgE levels. Their interleukin 5 levels were lower, as were their eosinophils. And their interleukin 13 levels were lower, as was the airway mucus cell metaplasia and hyperresponsiveness. All of those are features of allergic asthma benefited by resolvin D2. But the gene I mentioned was the receptor for resolvin D2, so we wanted to see if the resolvin D2 benefits were related to engagement of that receptor. And so we obtained a receptor antagonist that blocks the receptor, and it totally prevented the beneficial actions of resolvin D2, really supporting that engagement of resolvin D2 with this receptor, DRV2, that was pivotal to the benefit that we were seeing. That receptor is broadly expressed on cells, white blood cells, that are relevant in asthma, and we obtained peripheral blood from human patients with asthma compared to healthy individuals, and it turns out their eosinophils in particular overexpressed the receptor for resolvin D2. It's almost as if the cells were asking for resolvin D2 by ramping up their expression of its receptor. And in experimental systems, we see the levels of the receptor as well as the ligand resolving D2 modulated in these responses. So this appears to be quite a potent signaling mechanism for protection of allergic type 2 inflammation, which is prominent in human asthma. And potentially it's a window into new therapeutics. So respiratory syncytial virus is a leading cause of hospitalizations during the fall and winter seasons for children. So pediatric intensive care unit doctors frequently have to take care of patients with RSV in their intensive care units. And it's quite a significant illness. The mortality rates have decreased, but they're still present. But the morbidity rates are high. And these are for very vulnerable early life infants, often less than 2 years of age. We also see RSV infections cause excess hospitalizations in individuals that are older or immunosuppressed, cancer patients receiving chemotherapy, for example, or in transplant patients otherwise receiving immunosuppressants. So RSV is a substantial cause of hospitalization seasonally. During the pandemic, when everybody was wearing masks and staying home, we saw very little RSV, and so there was very little of these hospitalizations. But once the masks came off and people resumed life outside of their homes, we've seen an enormous surge of RSV infections globally. And so it's created a substantial problem for many patients. So having RSV treatments to either prevent the infection, such as a vaccine, or medicinal therapies to help decrease the severity of RSV are important, especially in those specific vulnerable populations I was mentioning. And so now there is a new vaccine for RSV, which is very exciting, but patients are still getting sick with it because the vaccine is not widely available yet. But that vaccine is being recommended for older adults in particular to try to help decrease the morbidity there, and in some of the immunosuppressed patients. And so the SPMs, it turns out, can actually enhance RSV host defense. And so there's a potential way for patients to think about, through supplementation, enhancing their antiviral host defense for RSV.